So we will go ahead and get started. We're really excited to have Ashley Schwartz here today to talk about team-based care billing and coding. To get started, do you mind putting it in presentation mode, Ashley? Perfect. We'll just do a few housekeeping slides so that you're prepared to submit this for CME. So on the screen are instructions. You need to text 66503 to the number listed here, ideally before the end of the day today or before tomorrow. And you have to complete the evaluation online by March 19th. We're also going to send a handout out to everyone following the call as well that will include these instructions so that you can refer back to the number and have the link to complete the online evaluation. You want to go next slide. And we are offering CME, we're offering medicine CME, so one AMA category 1 credit, nursing CE, 1 ANCC contact hour, pharmacy CE for 1 ACPE hour, and dietetic CPEU as well. So if you're in any of those disciplines, you are able to go ahead and claim 1 hour credit for attending this presentation. And then just with our disclosure, so Dr. Lauren Ashman, our program director, will be presenting the second half of this presentation on billing for non-face-to-face care. And she does have stocks in publicly traded companies in Abbott, AbbVie, Johnson & Johnson, and Merck & Co. Okay, and with that, I will hand it over to Ashley to go over some of the elements of team-based care billing and coding with you. Thank you, Ashley.
Thank you so much, Jackie, and I'd like to thank Dr. Ashman for inviting me to come speak to all of you today. My name is Ashley Schwartz. I am a licensed social worker, and I work with the Michigan Institute for Care Management and Transformation. My goal today is to give some high-level basics of team-based care, billing, and coding. And feel free to put some questions in the chat, because I do know towards the end we'll be able to do some Q&A. So just to reference, this presentation was materials based off of our Foundational Care Management and Codes and Billing Opportunities course developed through a collaborative effort within Michigan Institute for Care Management and Transformation. Throughout the presentation today, I'll be highlighting some resources that are available under our website for future needs. So I want to set the expectation that this presentation does build upon team-based care, focusing on reimbursement for care management services, specifically related to Blue Cross Blue Shield of Michigan and Priority Health. However, some details discussed may be like other payers. So you might have questions related to, Medicare, Medicaid, some of those other, specific HAP payers, but we're really focusing on Blue Cross and Priority Health as well. So today's objectives, our goal is to identify members of a care team, define healthcare coding and billing, describe 2 common healthcare coding classifications, explain the importance of documenting within the encounter, and illustrate how a care team member may impact risk adjustment in the financial model of practice. So I want to set the foundation. From the Agency for Healthcare Research and Quality, the primary goal of medical teamwork is to optimize the timely and effective use of information, skills, and resources by teams of healthcare professionals for the purpose of enhancing quality and safety for patient care. So team-based care, what does it take? It takes a holistic, person-focused, and family-centered approach, care coordination across settings and organizations, a common set of quality outcome metrics, and reimbursement for care management services and care coordination. So there's been a big shift from fee-for-service to value-based reimbursement. And of course, billing the encounters contributes to the success of value-based reimbursement. So now we want to talk a little bit about the importance of productive interactions, and sustainability. So it starts with those conversations. Many productive interactions with patients can lead to improved outcomes. We know this, and it is measured at a population level. But not only that, you have the ability to bill for those interactions that you're having with your patients and their caregivers. This will sustain the support of care management through payments and successful incentive programs. So we want to introduce your care team members. So at the top, you will see we have our licensed professionals. Of course, we have our physicians. We have our advanced practice providers, also APPs, registered nurses, pharmacists, master social workers, registered dietitians, and certified diabetic educators. We also want to highlight our unlicensed professionals. We have our importance in our clinics, such as our medical assistants, as well as our community health workers. And some people, the community health worker is a new role for some individuals, but we are really highlighting them because they are wonderful in our community and can help our patients and our practices. So with that being said, our unlicensed professionals will work under, a written protocol, or also known as standing order, signed by the physician or APP in your offices. On our website at MICMT, we do have an example document, what we call our scope of service document, that is available for you if this is something you're interested in having. We also want to highlight those extended members that we don't always think about. The front desk staff, our schedulers, our billers and coders. They are so important as we think about who is in our care team. It is truly a team effort. So billing and coding chain of accountability. So I always think of the football analogy that the physician is similar to our quarterback. The quarterback leads the team. We have our advanced practice practitioners. We have our care team members, our licensed and unlicensed, and our billers and coders. If we're not all working together, our practice will not be successful, and our patients won't have what they need. So defining coding. So we just wanted to quickly review the difference between coding and billing and claims. There is sometimes a confusion of really what does that mean? So healthcare coding, it involves the billable information from the healthcare record in reviewing clinical documentation. Healthcare billing uses those specific codes to create the insurance claim and bill for patients. And then we have our healthcare claims. So that's where the healthcare billing and coding intersects to form the backbone of the actual practice's revenue. So we want to highlight the importance of documentation and really what is the trigger for coding and billing. Well, that starts with you. It starts with the time of what is actually happening. So we use the example, well, if it's not documented, there's no proof it happened. So clinical documentation improvement is a process that continually looks for ways to best maximize the healthcare record in targeting with the goal of providing and completing an accurate picture of a patient's condition and the care services they receive most often, specific to the setting where services are provided. So as an example, as a licensed social worker, I'm working in the practice, I'm assisting the patient, I'm on the phone with the patient, I set my interventions up, and then I document it right there in the medical record for proof. So we want to talk a little bit about coding for specificity, ICD-10 CPT and HCPCS codes. So we all know that documentation should be as specific as possible and drill down. So as I mentioned, what did I do? What did the patient say? Things like that. But we really want to be specific to the coding as well. And again, it's mandated by HIPAA. Specificity and coding has a significant impact on HEDIS metrics and risk scores as well. So as I mentioned, we've really moved away or are moving away from that fee for service, and we are moving into that value-based reimbursement, That's where risk scores can also be very important. So I have just a few examples on the screen of what I mean. So chronic obstructive asthma with acute exacerbation, We don't just say COPD. Hypertension, heart disease with heart failure, we're no longer just saying heart failure, hypertension. Again, just highlighting some examples, and I know you are all here as you work within the MCT2D CQI model. And so obviously we can see on the right-hand side, we all know how important it is to really be specific when we're talking about our diabetic patients as well. So we have, you know, our diabetic type 1, type 2, and really narrow, bringing it down, as you can see in the right example. So now I want to talk a little bit about care team procedure codes. We are highlighting the 12 procedure codes, and these start with the G9001, which is the coordinated care initial assessment, and the G9002, which is the maintenance. These are also known historically as a face-to-face code. However, since COVID, actually, there has been the open guideline that if a patient is unable to come into the office and has declined any sort of video telehealth visit, that these codes can be done telephonically. Specifically with the G9002, we do want to highlight that if it is greater than 45 minutes, you can quantity bill. We have our group education. So our 9, 8, 9, 6, 1, and 6, 2, you'll see that those two codes are based upon the number of patients that are participating in your group education, and they are a maximum of 30 minutes. So you'll see 1 versus 2 in the total time. And again, those are eligible for quantity billing. We have our phone services. So the 98966 through the 98968. Those are super important opportunities. So when you're reaching out to patients as a care team member, as I mentioned, we have our licensed and our unlicensed, and the phone service codes are available for outreach from our medical assistants and our community health workers. We do want to highlight that those individuals are eligible to use these phone services under the Blue Cross guidelines. However, I do want to highlight that Priority Health does not allow. They have a set list of their qualified healthcare professionals as well. They are time limited, as you can see. And then we have our care coordination codes. So these are those non-patient directed codes. So the patient is not involved. These might be examples of reaching out to, as it says, your patient-centered medical home neighborhood. So maybe reaching out to home health care, maybe reaching out to some transportation services, those resources that are going to allow that patient to get some help. And again, these are time-based codes. I also want to highlight these are per a calendar month. So for example, the 487 must be within 31 to 75 minutes, and it is within a calendar month. Team conference, the G9007, is a super important code because it does give you the opportunity to connect back with those physicians, your quarterback, to talk about the patient. Maybe there's some concerns that the patient identified at home and we need to follow back up with the patient to address the treatment plan. So that is an opportunity for you as a care team member and the physician to have a discussion and be able to bill for that service. The G9008, and this is a physician-directed code, and this is when a physician communicates with another physician on the care team member. So maybe the primary care doctor is reaching out to the cardiologist or the endocrinologist and having that conversation about a treatment plan. That is a billable service. And then lastly, we have our S0257, and that is your counseling for advanced directives. So we're going to talk a little bit more about the codes later in the presentation, but I did want to highlight the codes for you. So billing for care team member activities is so important. Billing for your services and being paid for the services places a value on what you do and helps the patient. Billing along with the care team incentive programs is how team-based care can be sustainable. And sustainability comes from engaging a minimum number of patients in a day. So at MICMT, we do have a recommendation that you have a minimum of 4 encounters on an average per half day, 8 or more. And as we look at sustainability, that is going to continue to grow. And later, as I mentioned, we are also going to talk a little bit about what that could look like a day in the life. We want to be sure you have a mixture of types of encounters. So as I mentioned, we have those face-to-face opportunities. If the patient's right there in the office, we also have those telephone services. So as a patient, exits the office and we want to follow up with them in a few days or set up a time, a weekly outreach, you have those phone services. And again, as I mentioned, you have telephone and virtual. And of course, lastly, billing consistently for services. I can't say that enough. So to highlight the process for revenue, we, of course, as I mentioned, document the encounter in the patient's chart, assign an appropriate code, we submit the claim electronically, interpret the payer's response, and then prepare for post-payment actions, audits, documents, request. So you can see, as I've gone through the first few slides, how our care team is so important. As a licensed social worker, I'm going to document my time with the patient. I'm going to select the appropriate code. So if I had that phone outreach, I would select the appropriate time-based code. And then I'm going to submit the claim. But am I going to submit the claim, or is I'm working collaboratively with my biller or coder? And then we have the payer's response. So for example, Blue Cross, what is the payer's response? And then prepare for those post-payments, so the return on investment, as well as understanding if there's any additional needs. So what are the key takeaways from the first few slides? Team-based care is derived from the chronic care model and is completely patient-centered. Sustainability of team-based care is identified important members of the care team, our nurses, our social workers, our dietitians, assigning appropriate classification of codes, the G9001, G9002, and then documenting services, therefore billing, and billing is consistent. So this next portion, I'm going to talk a little bit about billing and the optimization opportunities. It is so important to match a diagnosis with what's going on. So care team members can take an opportunity to make sure that the patient's diagnoses are correct by reviewing the problem list and making recommendations to our quarterback, our provider. Other optimization opportunities could include preventive care, chronic care support, our social determinants of health, and then HCC, hierarchy care coding. So this slide is going to give you just an example of what it might look like if working with a patient. So I'm from a billing perspective or doing an outreach for gaps in care. So we're reaching out to the patient, and then is there a determination if this patient has a chronic disease or not? We're going to determine if yes or if no, and what kind of service am I providing? So I'm providing outreach maybe because the patient hadn't had a mammogram. And so I'm going to do that outreach because there's that gap. So now I would have an idea of what appropriate code I could use for some of this outreach that I'm doing. And another super important code that we hear a lot is this counseling and care coordination of care. We've had really good feedback that this is a super valuable code to use when you're just uncertain, or if the patient doesn't have a specific chronic condition, but you're doing some outreach maybe for that SDOH. So when to use a Z code for SDOH. So this is just highlighting the importance of the availability of Z codes. We're enhancing, we're doing those assessments with our patients to determine if there is a barrier or a need related to, transportation, financial support, housing, food insecurities. So there are codes available should you need them based on the outcome of that screening of an SDOH. And this is just an example a resource that it will take you to list all of the Z codes available. And again, the most common Z codes, and for the purposes of billing, we did want to highlight that historically that homelessness has been one of the top Z codes used. And there are several payers such as Blue Cross and Priority Health that are offering incentive plans surrounding the SDOH and the usage of the Z codes. So now we're going to show from a clinician's perspective what a day in the life could look like. So this is just an example of a schedule, because we do recommend that all care team members should have a set schedule. There could be blocks throughout the day. So you'll see right here at the morning, you know, we encourage huddles with our care team members to prep for the day. And then you'll see that in the beginning of the day, this individual did transition of care. So that 8:30 to 9, you're working through your list, who's been in the hospital and discharged, and let's do some of the outreach to get those out of the way for the day. And then now we have, by 9 o'clock, we have a new patient visit coming in. Excuse me. And then as we work through our day, we have a slight block from 10:30 to 11. So maybe we're catching up on some documentation. We're doing maybe some follow-up calls based on patients you'd seen earlier in the day or earlier in the week. And then again, already at 11, we have a new patient visit. By lunchtime, we have some opportunity, you know, of course, take your lunch, take care of yourself, but then maybe have some opportunity for some additional follow-up. Maybe you need to do some outreach to those resources that you need to set up. So care team members should make sure to comprehensively bill for all their interactions. The frame of mind should be that all interactions are billable. So the question is, how do I bill? Not should I bill? And again, this is just another way to look at a schedule. So morning block versus an afternoon block. And I want you to ask yourself, how close does this mirror your experience? And do you see any barriers from what your day in the life looks like versus what this looks like? I mentioned earlier that from a sustainability perspective, we encourage you to have at least 4 encounters per half day. And so you're going to see, just looking at this, that within the first half hour, they had a team conference with the physician on 3 separate patients. And this asterisk just means multiple encounters. And then as I'm walking through just this morning block, we had that initial patient visit, and then we had some additional care coordination outreach. Again, G9002, that's that maintenance follow-up with a patient, and then a team conference with the physician. So just highlighting some of the encounters. You can see that and as we get further into the presentation, we're going to walk through some scenarios, but you can see that multiple codes can be billed in multiple days. Or excuse me, on the same day. So this is just the summary of what the day looked like for that clinician. This right here showed 14 billable activities for the day. Now, again, please be mindful that this is an ideal situation. Your schedule might look different. So applying care management codes to practice. Review and understand your billing codes and their application in your work to perform within the practice. Select the appropriate billing code in various scenarios, and documentation is key. So again, here's just a highlighted list of all of our codes that I mentioned earlier in the presentation. And now we're going to go ahead and jump into some scenarios that those codes could be utilized. So I've mentioned transition of care, chronic conditions, chronic disease management, social determinants of health, those specialty and primary care interactions, gaps in care, as well as substance abuse. So this is an example of what a care management workflow could look like. We start off with an initial outreach or maybe cold calling patients based on GAPS reports. We have a team conference to talk about some of those patient interactions. Or maybe we're talking with our physician about who would be an important person to follow up with today. So that morning huddle, or even midday. We have the physician interaction. So Dr. Rachel recommended that maybe a care manager follow up with Mrs. Smith, or maybe Dr. Jones contacted Dr. Rachel about a cardiology consult or treatment intervention. We have our group education opportunities. So maybe our diabetic educator is having some group sessions this afternoon. We have our social worker who also has a consult to follow up. And again, this could be multifaceted. In your practice, you might have all of those different types of individuals, or maybe you only have a social worker or a nurse in your practice. And then we have the communication between the nurse and the social worker. So again, just an example of what a care management workflow could look like. So now let's jump into a team-based care scenario. So Ms. Smith completes an in-person office visit with Dr. Jones at 9 a.m. During that visit, Dr. Jones refers Ms. Smith to Eric, the nurse care manager, for diabetic management. Ms. Smith indicates she consents to meet Eric today. Eric and Ms. Smith discuss previous diabetic management, including diet, medication, risks, symptoms, and home support. Eric and Ms. Smith establish a care plan related to medications, diet, and coordinates her follow-up appointments to see Dr. Jones in 6 to 8 weeks, and completes weekly telephone calls with Eric. This time, total time was 40 minutes. So let's think about those codes that we previously talked about and what code would we use for this scenario. So if you said G9001, you were correct. This opportunity was that it was a face-to-face visit and it lasted longer than 30 minutes. So it resulted in a care management plan that all team members and the patient agreed to. So let's jump forward. Ms. Smith contacts Eric in 2 weeks, reporting symptoms of dizziness, lightheadedness, blurred vision, and some times of confusion. Ms. Smith and Eric review her medications, and she reports her recent blood sugars from her CGM. Eric generates the report and contacts Dr. Jones regarding concerns. Dr. Jones modifies Ms. Smith's treatment plan, medications, and recommends a 1-week follow-up. And then Eric contacts Ms. Smith to educate on changes of medication regimen and side effects that occur. Eric assists with scheduling a 1-week follow-up appointment and schedules a call with Ms. Smith in 2 days. So you're going to see at the top, we had a 15-minute phone call between Eric and Ms. Smith. We had a 10-minute team conference with Dr. Jones and Eric. And then we had a 15-minute secondary follow-up call between Eric and Ms. Smith. So think about your codes. So we have multiple codes that we could bill for this interaction. We have our 21 to 30 minute 98968 because we had a 30-minute call between the two calls that equaled 30 minutes. We had an interaction between our provider and Eric to talk about her treatment plan. I do want to highlight that conversation is required to be face-to-face or via telephone or video. You cannot have EMR messaging, portal messaging, or emails in order to bill this code. And then we also had that Eric generated the CGM report and prepped it for Dr. Jones to review and interpret the CGM data. So we can also include our CPT code for that, the 95251. So in N, you had three separate distinct services. So documentation suggestions. So we want to always recommend that documentation should include the following at minimum. And you can kind of see here, everybody's EMR looks a little bit differently. We all have a little bit different templates involved. And I want to highlight that different insurance companies, different payers have recommended different requirements. And so this is a high level documentation goal. And you can kind of see it highlights the duration of visit, the type of visit, who was involved from a patient, maybe the caregiver, as well as maybe the physician. Consent for services, you'll notice earlier in our scenario, I did highlight that Ms. Smith did agree to talk to Eric. What was the treatment plan? We want to highlight our care plan. So what did the patient agree to and what was our goals? Ideally, add the patient's SMART goals if possible, if they've been identified and when it's appropriate. And then lastly, I did want to highlight the CGM report. And again, we recommend and understand that different organizations have different templates. So this is just a high level brand, the sensor placement and removal dates analysis. I have heard from certain organizations, they can take a screenshot and put that right there in their report. And then of course, the physician interpretation. So key takeaways. The billing codes can be utilized in many common clinical workflows within your office setting, but is not limited to at least transition of care, social determinants of health, those interactions between primary care and specialties, gaps in care, and substance abuse. Be sure to appropriately document your encounter in detail and according to the billing rules specified by the individual insurance carrier. So now I've included some frequently asked questions that I do know, I believe towards the end of our call today, we're going to do some Q&A based on questions that were received during the registration process. But I did want to highlight just some of the questions here, specifically related to the PDCM codes. So can a care team member bill for advanced care planning? Yes, they can. It is not required to have a referral from a physician to bill that S0257. Can I get reimbursed for time spent coordinating services with providers? So we talked a little bit about that. The home health specialty offices, community resources, that is that 99487 and 99489. And it is a non-face-to-face clinical interaction with the neighborhood. So it is required to be at least 30 minutes in a calendar month. Some of the things included in that are finding drug financial programs, applying for patient assistant programs, coordinating the prescriptions within a specialty pharmacy. But I do really want to highlight what is not included. Checking benefit coverage, prior authorization, and completing your documentation. And then lastly, just the top question talks about who is available and allowed to bill for PDCM. And yes, unlicensed care team members such as medical assistants and community health workers are able, under Blue Cross Blue Shield, are able to bill for those services. Please be mindful that other insurance companies such as Priority Health does not allow medical assistants or community health workers to bill for those codes. They do have additional qualified healthcare professional requirements. Now, lastly, just want to highlight some of our resources at MICMT. We have our website, you can see some screenshots. We have billing, and within billing, we have the specific codes. We have reference documents, additional FAQs available to you. We also offer multiple events and webinars available for continuing education as well as training opportunities for all of you. And now here's again just some additional resources available to each of you. As I mentioned, our training opportunities, we have our patient engagement course, intro to team-based care course, and our foundational billing course, which parts of this presentation were derived from. And now I believe I'm going to turn it over.
Ashley, can we actually pause for a minute and go through some of the questions in the chat before we move on to Dr. Ashman's portion?
Yes, sorry, I couldn't see the chat while I was presenting, so I do apologize.
Sure, I will go through and I can go ahead and read them to you. So the first question is like, do these codes apply to the Medicare Advantage population as well?
Yes.
Okay, perfect.
It isn't. I do want to say it is important, and I do know Lori Bachter is also on the line from Blue Cross, but I've worked really closely with her, and I will say they will always recommend anybody should check coverage, benefits coverage before billing for PDCM. And there is a list of groups that have opted out of the PDCM program. And that is also a reference document available on the website as well as with Blue Cross.
Okay, great. The next question is, will there be any changes to allowing the phone calls with the end of the public health emergency?
When you say allowing the phone calls, are you referring to the face-to-face the G9001 and 2 being allowed to be done via telephone versus in person? If that is the case, it is officially changed since the public health emergency.
Yeah, and Lori, I believe you gave us the answer to that question, at least with those two codes. And the answer was yes, they can still be billed telephonically as long if the patient doesn't feel comfortable coming in or if they don't have transportation and it is documented in the chart.
Correct.
Okay. With the 9948, oh, sorry, go ahead. Okay. With the 99487, if it is billed per month, do we bill those each individual instance, even if it doesn't meet that time requirement?
So this is going to be based on your individual workflows within your organization, but no, you shouldn't be billing them. That's where we recommend having those conversations with your billers and coders. Some organizations have it on the back rule engines on the back end, so the clinician would do what they follow their normal steps every time, and then on the back end it stops it, and once it goes out at that end of that calendar month, regardless if it meets the time requirement.
Okay. For a team member to bill the phone codes, do they need to have care management training? There's been an impression that in order to use the care management codes, they must be a recognized care manager with Blue Cross Blue Shield or Priority Health.
So yes, for the 12 codes that we talked about today, for Blue Cross, for the payers, specifically Blue Cross and Priority Health, they do require individuals to complete intro to team-based care within 6 months of billing the care management codes.
Okay.
And that is for both licensed and unlicensed care professionals.
Okay. Should we use the Z code if doing preventative gaps outreach if the patient does not have a chronic condition or diagnosis?
That is, yes, you can use the Z codes as well as the code I mentioned earlier. I'll have to take a quick peek. I don't remember it off the top of my head, but Peggy, I will put that code in the chat.
Fantastic. Thanks, Ashley. To bill these codes, does every patient need to be engaged in care management?
So I guess when we're thinking about care management, we, ultimately we want our patients to be engaged in consenting for services. There is opportunity to bill these codes if a patient declines services. But I guess I think the important piece is understanding what engaged in care management means.
If a provider reviews and signs off on an ER follow-up call made by an MA, can the phone codes be billed, such as 98966?
I'm sorry.
Becky, can you repeat that one?
Yeah.
Because I guess I'm not understanding.
Yep. If a provider reviews and signs off on an ER follow-up call that's made by a medical assistant, can the phone codes be billed, such as 98966? So the medical assistant's making the call, but the provider reviews and signs off on it after a patient's discharged from the ER.
I know that we do allow the telephone codes to be billed when someone has been into the ER. I don't see an issue with that, because ultimately the physician is the one that's responsible, right? So yeah, I would say yes.
Was that an inpatient question or an ED question?
It was an ER.
Right.
Yeah, we also, again, be mindful that the medical assistant should have, to complete services, should take the training as well.
Do patients ever have to pick up the out-of-pocket costs for these care management codes due to either deductibles or copays?
So there is no cost share associated with these telephone or with these procedure codes for PDCM. One thing I do want to caution, however, is if you are rendering a service to a member that is considered a hosted member, and those are people that live in Michigan but have coverage through another Blues plan, the benefits are based on that other Blues plan. And so ultimately, more than likely, they will assess cost share for their enrollees. This PDCM and no cost share only applies to Blue Cross and Blue Shield of Michigan enrollees.
Okay, perfect. There's a comment I've noticed as the care manager, the CGM report 95251 does not always get paid when they bill the code, but the code, it does get paid when the doctor does with a visit with the patient.
I'm going to lean on Lori if she can take that. Unfortunately,
I was going to lean on you because I don't know that code.
Yeah. So the CGM codes, I mean, our understanding is that, all codes are billed under the direction of the physician.
Right.
So I think in the example that you just provided, if the rendering provider is not the billing provider, then maybe that's why it's getting denied. But I think that might be an example you'll have to take back to the payer to determine the differences between the two examples.
Okay, so a G9001 or G9002 and a G9007 can be billed on the same day if a patient was seen in the office and then a discussion was had with the provider afterwards to discuss the plan. Is that accurate? Okay.
Technically, yes. However, in most cases, you're not billing a G9001 and a G9002 on the same patient the same day. Mm-hmm. Again, you want to make sure for that initial assessment, that G9001, you can meet the requirements for that. I find in most examples, you're picking one or the other because you haven't met the guidelines for that G9001. So you're most likely billing a G9002, but absolutely can those codes be billed simultaneously.
Okay, and it was actually either one of those with the 007.
Correct. And we highly encourage that because that's that conversation with the patient, and then conversation with the provider.
Okay. And then it looks like there's a little bit of questions about the G9008 code. Someone said that the physician coordinated care oversight services was a code billable by the physician at the initiation of care management as an enrollment fee. This was agreed to by the patient, physician, and care manager with all three parties present and in agreement. They wanted to know when this changed, and then also just interest in reviewing the G9008 code a little bit in more detail.
So in this case specifically, Brenda is not wrong. There is the physician coordinated care oversight code has always been that initial a referral for a patient, a care manager, and a physician. And specifically to Priority Health, that is their guideline that the patient should be involved in that referral. So there has been no change. However, Blue Cross also allows that interaction between a specialist or maybe the PCP and the patient, and prior to a hospital visit, the PCP is talking to the paramedics at the home, or that patient has a home paramedic coming out to do checks. That conversation to prevent maybe a hospitalization is also a billable opportunity under that G9000 or G9008. And please, Lori, you can jump in here as well if I'm misspeaking or if you have
you actually have it all. You've covered it all. So an APP cannot bill the G9008 code, guys. That is strictly a physician MDDO code.
Okay, thanks, Laurie. The question, do billing charges get applied to the patient's deductible? We already covered that there's not a cost share there. G9001, can this be billed with the patient if they don't come into the office, or does it not have like the video option?
That is correct. It can be done telephonically as long as it's documented that the patient doesn't have the options to perform a video visit or doesn't feel comfortable coming into the office. It can be completed telephonically, but it must be documented.
Okay. Just a couple more. Engage with care management. Currently working with the care manager. Do they have to be working with the care manager in order to build these 12 codes? Or if an MA is setting up home O2 or home care, can the coordination of care code be billed?
Yes and yes. So yes, obviously we want to encourage engagement in care management and longitudinal care management opportunities, but you can build a follow-up, such as a telephone code to really work with the patient and encourage the patient to participate. But there could be opportunities that you're providing a resource. The patient had a positive SDOH and you're providing a resource, but there's no additional needs. So then you're maybe only having 1 or 2 phone calls with the patient. So you're using the telephone calls. And then yes, if a medical assistant is coordinating care to set up home O2, that's when you would use those care coordination codes, the 99487 and 89. But just be mindful that it is a requirement of at least 31 minutes in a calendar month.
Okay. And then the care management training, it only needs to be completed 1 time within the first 6 months of billing, correct?
Yes.
Okay.
You are required to have longitudinal care, longitudinal education, and that can look a little differently. So if you are a licensed professional, you are required to get professional education for your licensure. So that counts towards that as well. But for your medical assistants, community health workers, we do require, in addition, they don't have that licensure requirement. So there is opportunities for 8 hours by providing, completing the educational webinars that we offer. A webinar such as this would be appropriate, things like that.
Okay. Laurie, I know you're saying only a physician can build the G9008. Does that mean that APPs, if a physician is over them, they're not allowed to bill it? It is only physicians?
I was on mute. It should only be a physician billing.
Okay, so only physicians can build G9008.
Yes.
Is BCN allowing G9008 to be used for ED prevention and collaboration like BCBSM is?
Can you tell me just a little bit?
It is my understanding that BCN for the PDCM program is following the same billing guidelines as BCBSM. So the answer to that would be yes.
Wonderful.
For primary care physicians.
For
only.
primary care, yes.
Okay. If care planning and care coordination occurs between a PCPM or PCP care manager and a specialist team-based care manager, but it is not 31 minutes, how can we bill for this?
You can't.
You can't. Okay. And go ahead.
Oh, I was just going to say, just be mindful of the time requirement. That is a part of the CPT guideline.
Okay.
Yes.
The last question, can G9001 be billed as on the same day as a hospital follow-up visit?
With the physician, or
How's the other one?
Mary, was that with a physician that you were asking about? Yes.
so yes, if the patient is being seen by the physician for a follow-up appointment, and the patient is being seen by a care manager to initiate care for care management services, and they complete it, yes, a G9001 can be billed.
Okay, we are through our questions. Thank you very, very much, Ashley and Laurie. We really appreciate it. And thanks everyone for being so engaged and asking all these types of things. I'm sure it was very helpful for everyone on the call to hear the answers to this. We're going to turn it over to Dr. Oshman to go over billing for non-face-to-face care. Dr. Oshman, do you want to share your screen so that you can control your slides and go through them? Or do you want to leave them as it? Oh, we are viewing your screen now. Okay, perfect. Yep, we can see them. I can't hear you great though.
Well, I wish I could make if I lean towards my computer.
It's just cutting out a little bit.
Oh, God. Got a headphone here. And I just
Not really.
Okay, it just got better. Keep talking. I'll see if it stays.
All right. And if not, I'm going to call in with the phone.
Much better now. Thank you so much.
I just want to say thank you. That was such a wonderful presentation. As a physician, I feel so grateful to the rest of our care team for doing all of the billing and coding work so that I don't have to know all of those codes. So I'm going to just narrow in on what might be more interesting if you're a nurse practitioner, physician assistant, or physician thinking about how you can optimize care with patients in between visits. And then we'll pull this all together in terms of billing these codes along with the ones that you just heard about. So you should see codes to know, and we're going to talk today about the online digital E&M codes, which are 99421 through 423, the telehealth CPT codes, which are 99441 through 99443, and CGM interpretation. So I'll give you a first example of one of my patients, and this is JG. She's 62. She has type 2 diabetes. She takes semaglutide, metformin, and glipizide, and we've prescribed her a CGM. She sees a nutritionist in our practice as well, and we receive her lab results and see that her A1C has now increased from 6.4 to 7.8, but I don't have any visit availability. So certainly I could use any of the care team codes and I could defer that education back to a staff member, but I can also decide to call this patient back myself to have this discussion. And so she sends me a portal message and says, Dr. Oshman, I'm worried about my A1C. Do you think we could change my semaglutide to that new medication you keep telling me about? So the first thing that we're going to think about is how to access her CGM report. And we can have our staff work with us in a variety of different ways to get this information for the physician or qualified health professional to review. But she's going to attach her 7-day food log and her CGM report, and my MA is going to route that to me for review. And then what you're going to see here is that there's a couple of different items. I'll move for you so we can see her time in range, and we can see that she's 88% time in range and 12% above. We can see her glucose patterns and identify some barriers maybe around mid-morning and lunch with increased glucose. And then we even get some interpretation considerations. Maybe we want to think about her meals and snacks high in carbohydrates or adjusting medication. And so we're going to get in that CGM report some opportunities to work with our patient. So thinking about CGM interpretation and billing, we're thinking about a minimum of 72 hours needed. So if our patient returns this report to us and there's only 2 days worth of data, we cannot bill for that. This must be performed by a physician or qualified HCP, healthcare professional, which could be nurse practitioner, PA, or clinical nurse specialist. And like you already heard, can only occur once per month, but this is not required to have a face-to-face visit. That code is 95251. And the Medicare RVU non-facility is 1.02, and the average is $97. So again, this is a real opportunity for us to do great work with our patients in between office visits and also get paid for our work reviewing their CGM. The documentation for CGM varies by payer, but in standard fashion, we're going to talk about why. Why did we order the CGM? And typically that indication is going to be some element of poor glycemic control. We want to do an assessment and interpretation, and you are welcome to just put a screenshot of that report in your progress note and then talk about what your recommendations and plan are. So we've assessed this patient, we know where they may benefit from changes, and then what is our plan? Again, typical documentation that we might provide. And so we analyzed this patient's CGM. We know she's adherent to her meal plan and her diet log. There's not a whole lot I want to change. And so rather than waiting for my next scheduled visit, I'm sending her a portal message with my recommendation. Dear Mrs. G, I agree with you. You'd benefit from that new medication, tirzepatide. I'm going to send it to your pharmacy. Please message me if it's covered and we can review safe use. And so in this case, she reads my message. She's going to get this new medication, and I give her some instructions for that. So this is an example of using our online digital evaluation and management service codes, and these are for online digital evaluation and management. These are not telehealth codes. This doesn't involve audio or video communication. These are just digital codes with communication for our patients, and they can be billed for up to a 7-day period with cumulative time during 7 days. So you can imagine with this patient, we went back and forth several times. And so our cumulative time was 11 to 20 minutes, and we could bill 0.5 RVUs for this. I'm going to go real quick because we just have a couple of minutes here, but we need to make sure that the patient has initiated requests. So I couldn't ask her to talk with me and then bill this code if I'm just reaching out for her test results. But because she reached out to me with a request to change a medication, that's considered to be the patient reaching out to me. And we need to make sure we have verbal consent. And so these are 2 disclaimers from 2 practices I've worked at. Both of them are different. Both of them inform the patient that we're going to be billing for these services. And so again, these are messaging codes. They don't relate to a visit we just had. So if the patient then came in to see me the next day, I would remove this code, and it does not include staff time, only physician and qualified healthcare professional time. I'm going to just move to the meat here in the last 2 minutes and skip some of these examples for time. But here's an example of a patient who called into the office because she had some questions about side effects, and I had a cancellation on my schedule. So I decided I'm just going to call her. I'm not going to have the staff schedule her for a visit with me. And this is where I might use the telephone E&M services. And these again are given in time segments, and these are codes 99441 through 99443. And so the key pieces here are this is unscheduled. So this is just for my callbacks to patients in my own administrative time. And again, the patient must have initiated request, and it can't be related to a visit that I just had in the prior 7 days or lead to just recommending an office visit. So some of you had asked about the final rules for coverage. We're going to find out more about 2024 later. What I can tell you is that in 2023, these codes have been extended to the end of the calendar year. Key points for you, just documenting the basics of your service, your SOAP note, your assessment and plan, and that your patient consented to the visit. And then I'll put the rest of this information in the information given to you with the slides after the presentation. We don't want to double up on services. So if we're having a staff member call back that patient, we don't want the physician to bill for that as well. So the biggest thoughts for us as physicians is we want to provide non-face-to-face care. We don't want to lock our patients into visits with us. And these are ways to use our administrative time to get back to patients right away. And we can use these in congruity with the other codes that you just just heard about. So I'll stop from there. I'm going to stop screen sharing. I'm sorry I went a little bit fast in our last few minutes, and we can answer a couple of questions, and otherwise we will put out all these answers to you in an email. Any questions?
Thank you so much, Dr. Ashman. We're going to look through the pre-submitted questions that we didn't have time to get to. And like Dr. Ashman said, we'll make sure that if any of the ones that you submitted while registering for the meeting weren't answered, that we send you one via email. So we will get those ones answered that we didn't get to today as well.
Excellent. We don't want to keep you over time. These are absolutely fabulous questions, and we will get them back to you.
All right, thank you all so much. We're going to get the slides out to you, including the information to claim CME later this afternoon. So thanks everyone. We really appreciate your time.
Thank you so much. Bye-bye.
Bye.